for today and would request them to please join us on stage. I would welcome Professor Shehbaz Qureshi. Sir, thank you for taking out the time. He's Professor of Cardiology, Consultant Interventional Cardiologist at the Heart Clinic, Islamabad. He's also the President, Pakistan Aspirin Foundation. I'll also welcome Professor Shahab Abid. He's Professor at Department of Medicine, Aga Khan University Hospital, Karachi. He's member of Executive Council of Asia Pacific Association Study of Liver. He's an active member of several national and international professional organizations, notably ACG and ANMS. He's a certified examiner and assessor of fellowship examination of CPSP for medicine. I will also welcome Professor Tahir Saghir, our third chairperson for today. He's Professor of Cardiology at NICVD Karachi, currently acting as Director of Clinical Research Department and Associate Director of Cardiac Cath and Intervention Department at NICVD. The Clinical Research Department has conducted several successful researches under his leadership. ACID-related disorders is a broad term that's used to describe a whole range of conditions from the Zollinger-Ellison syndrome, where ACID is entirely responsible for the problems, to aerophagia and motility type non-ulcer dyspepsia, where ACID plays little role in the dyspeptic symptoms. Careful evaluation of the patient's symptoms is required to establish the basis, and then careful selection for effective treatment may be needed. I'll request these symptoms are the basis for advising on the most effective management, and as medicine is ever evolving in nature, I'll request our first speaker, Professor Dr. Lubna Kamani, to present her talk on a new era for the treatment of acid-related diseases. Professor Lubna is President, Park GI and Liver Disease Society. She's Publication Secretary for PSG, Co-Chairwoman in Hepatology Forum of South Asian Association of Study of Liver. She's a Professor of Gastroenterology, Consultant Gastroenterologist and Hepatologist at Liaquat National Hospital and Medical College, Karachi. Ma'am, thank you for taking out the time. Please join us and take over.
Thank you very much for the kind invitation. And I would like to thank the organizer for giving me this opportunity for presentation in this prestigious conference. Today I was told to basically present about vonoprazan because it's a new treatment and in acid peptic disease, and basically most of the doctors here does not know basically how to write this medication. So vonoprazan is a first-class potassium competitive acid blocker that has been available in the market in Japan. Basically it was launched in Japan and initial studies were done in Japan way back in 2015. And then this vonoprazan marketed in South Asian countries in Pakistan last year. It's a reversible potassium competitive inhibitor. It's more potent, almost more than 300 times potent in acid suppression as compared to conventional proton pump inhibitor like lansoprazole. And it's a reversible potassium competitive inhibitor. So the dosing is usually we give it 20 milligram once a day for gastric ulcers and duodenal ulcers. We can give in 10 milligram in basically for prevention of reflux esophagitis, and if symptoms are not better, we can increase it to 20 milligrams per day. And 10 milligrams daily we can also give in prevention of in those patients who are prone to get gastric ulcers and duodenal ulcers, especially those who are on non-steroidal anti-inflammatory and low-dose aspirin. And recently, a couple of days ago on 4th May, the FDA has approved vonoprazan for Helicobacter treatment because we are seeing more resistant cases for Helicobacter because of less acid suppression, because of antimicrobial resistance, as the previous speakers talk about regarding the antimicrobial resistance. So we are also seeing this in Helicobacter treatment. So the dose is in combination with amoxicillin and clarithromycin or amoxicillin. It is for 14 days. Sorry, there's a misprint. It's not for 7 days, it's for 14 days. So regarding the pharmacokinetics, I won't be going detail into the pharmacokinetics, but if we compare the pharmacokinetics of vonoprazan with other PPI basically, so you can see that the half-life of vonoprazan is much longer as compared to other conventional medications. So what's the mechanism of action? Mechanism of action is basically gastric parietal cells. It's a competitive enzyme inhibitor. It has long half-life. It is more stable in acid. It's high accumulation in canaliculi and very slow dissociation rate. And it has 24-hour potency, so you can give it once daily basically, except in Helicobacter treatment where you have to give twice daily, 20 milligram. So what's the uniqueness basically of this drug? Why to give this drug? It is more potent. It can be given once daily basically, and it is accumulates in the resting gastric gland is higher than an actively secreting gland. And one thing which you see is basically, it's not working. Okay, I'll throw it up. So if you see that if you start on day 1, okay, so if you start on day 1, the response will continue to increase till day 7. So it is not just equivalent to a conventional PPI where the response almost stays same or with placebo, but the response will continue to rise from day 1 to day 7. And it has a long-lasting acid suppression as well. Another advantage is it is not related with meal time. So you can give it with meals, before meals or after meals. And again, the blood concentration remains the same as compared to other conventional PPI in which we give before meals, the omeprazole. What about the erosive esophagitis? If you check all erosive esophagitis patients, and this is a study in which you compare with lansoprazole, basically, the vonoprazan was better as compared to lansoprazole in all classes of erosive esophagitis. So what about the recurrence? And as you see that if we see that the recurrence of esophageal erosive esophagitis as compared to lansoprazole, vonoprazan was better. And if you compare the dosage, 20 milligram, 10 milligram, the 20 milligram was even better as compared to 10 milligram dosage. So the nighttime and the daytime heartburn. Usually when you give proton pump inhibitor once daily, the patient often said that we have nighttime reflux. Initially in olden days when I was a fellow or a junior consultant, we used to give H2 receptor blocker for nighttime reflux. But now it is banned. We don't get, ranitidine anymore for the nighttime reflux symptoms relief because it was linked to some oncogenic mutations, and there was increase in cancer-related deaths with H2 receptor blocker. So if we compare vonoprazan with lansoprazole, the daytime and nighttime heartburn was much better and much relief as compared to conventional PPI. So this was a study which was done in Japan, in which there was efficacy of vonoprazan for gastroesophageal reflux symptoms in patients with proton pump inhibitor resistant non-erosive. And what they concluded was that changing the medicine from PPI to vonoprazan was significantly associated with improvement in GERD symptoms. So what we are doing is, what I'm doing is, those patients who are on PPI for long period of time, and now we have changed PPI to various classes, still having symptoms. So the clinical evidence of H. pylori, if you see in all patients, vonoprazan do better in H. pylori eradication as compared to PPI, lansoprazole, even in resistance cases. And the vonoprazan can be given as a dual therapy, which means we need to give vonoprazan twice daily with amoxicillin, or we can give a triple therapy in which we can give vonoprazan, amoxicillin and clarithromycin. So those patients who cannot, tolerate clarithromycin can be given dual therapy, and the response rate is similar. So the FDA approved just a couple of days ago, so this was a big, news in GI community, because after a long time, another acid suppression is now is available in the market, and we have something to write, something to give benefit to the patient. especially those who are resistant. This was a recent study which was done by one of our colleague, Professor Fayaz, locally, and it was recently published on vonoprazan, and it was a randomized controlled trial on vonoprazan and amoxicillin dual therapy versus standard triple therapy, which we are using these days with proton pump inhibitor. And what they saw was that the results were comparable. The H. pylori eradications were comparable, and in fact, the side effects was lower in vonoprazan group as compared to conventional PPI group with triple therapy. So what about the special population? Because when we are sitting in the clinic, you have patients with renal failure, you have patients, pregnant patients, liver disease patients. So you can use vonoprazan in patients who have renal dysfunction, but you have to use it with care, and you have to do close monitoring. And also you can give it in liver disease patient, but if the patient has acute hepatitis, or if patient has started having hepatitis, then you need to stop this immediately. Vonoprazan can be used in elderly patients, but not in patients less than 18 years of age, so still it is not approved in pediatric population. Vonoprazan is not indicated in pregnancy or should not give in patients who are lactating, so we need to avoid that. Keep that in mind. Before prescribing vonoprazan in young female, married female, you need to make sure that they are not pregnant. And a drug is basically metabolized by hepatic, CYP3A4. So what questions to ask yourself? Are there any unmet medical needs that require addressing? Why do we need a new drug? We have ample, many PPI basically treatments. And what are the limitations of PPI? The treatment rate, the duration of symptomatic relief. Are there any challenges associated with patient compliance, and how to treat PPI resistant or refractory cases? Basically, this medication comes when the patient is not responding, or they are on PPI for last many, many years, and now the symptoms have relapsed. So the current management basically of acid peptic disease is long, but to summarize, it's lifestyle modification. This is very important, that you have to, if there is reflux, you have to ask the patient to pop up their head end, and the last meal should be 3 hours before the bedtime. And weight loss is the key basically, because if they have large bellies, then the reflux problem will stay. And then there are other medical, that there are multiple proton pump inhibitors, then there are surgical, basically fundoplication or magnetic ring, and there are now various endoluminal therapies which are available worldwide, especially in US. There are transoral incisionless fundoplicator, Medicus ultrasonic surgical endostapler, and the most famous is the Strata device, which is a radio frequency energy delivery to lower esophageal sphincter. So approximately 10 to 40% of the patient with GERD fail to respond symptomatically, either partially or completely, to PPI. The proportion of patients with persistent troublesome symptoms despite one daily use PPI is 32% of heartburn and 28% of regurgitation, as reported by randomized control trial. Meta-analysis have found that more than 25% of patients fail to respond to PPI therapy with erosive esophagitis and NERD. So what are the challenges associated with PPI? It requires an acidic environment for activation, in which PPI are unstable as well. The effects of PPI influenced by cytochrome P450 polymorphism. They provide maximal acid suppression after 3 to 5 days of dosing. For optimal efficacy, PPI should be taken at least 30 minutes before breakfast, whereas vonoprazan you can give it even after meal. It's not related with meal time. Reflux symptoms of GERD are not sufficiently relief after first dose of PPI in 2/3 of patients because of slow onset of action, and in vonoprazan it's rapid onset of action, plus it's a 24-hour coverage for the acid suppression. Acid inhibition during the nocturnal period is weaker, and approximately 25%, as I've said, they experience symptoms at night basically, with one morning dose. So you have to give PPI in double dose basically. So you can have lifestyle modification. You need to increase the compliance. You have to call them periodically. You have to ensure them that they are taking proper dosing time, duration of therapy. You have to split or double the PPI dose and switch to another PPI if the patient is not responding. So in patient-related issue is with non-compliance to treatment, because these are long-term treatments. So patients usually sometimes take it, or you take it with on-demand basis. If they need to take it for twice a week or less than twice a week, then we can tell them to take on demand. In one study, only 46% of patients dosed for PPI optimally, and 54% who were dosed were suboptimally. They were either not taking it properly, or they are taking it at bedtime, or they are not taking before meals. And they are not, most of the patients, they eat, especially when I did clinic yesterday, after 4 to 5 days of holidays and festival, people had a lot of, heavy meals. And most of the patient I saw yesterday was with this acid peptic disease. And I had to increase dose temporarily, because they were stable for last many months, and now after having many fatty meals, their symptoms are relapsed. So lifestyle modification is the key. So we have come a long way, basically. If you start when I was not even born, the H2 antagonists were there. Then there was change in era in 80s, the PPI, omeprazole was there. And then there were various omeprazole. We have lansoprazole, we have dexlansoprazole, esomeprazole, and now we have another treatment, 2015, and recently FDA approved PCAB inhibitors. So in summary, clinical superiority versus PPIs, it's maintained pH of more than 4 and relief heartburn throughout the day. It's lower erosive esophagitis recurrence rate, faster healing of esophagitis. There's improved, especially in PPI resistant cases, when sometimes you are stuck. Even increasing the dose does not improve the symptoms. So now we have another medication to write for the patient, and has comparable H. pylori eradication with, in some of the studies, with less side effects. It's rapid, potent, and durable acid control. So these were the references that I used while quoting various studies. So vonoprazole overcomes many of the weaknesses of traditional PPI therapy. Vonoprazole is superior to conventional PPI for suppressing acid secretion, especially at night time. No difference in efficacy depending on CYP2, C19 genotype status.